Let's now welcome our next speaker. Dr. Todd Korthuis is a general internist, addiction medicine specialist, and clinician scientist. He began his clinical career treating patients living with HIV and has practiced addiction medicine since 2004. He serves as head of the section of addiction medicine at Oregon Health Sciences University. Todd's NIH-funded work focuses on the integration of novel addiction treatment and prevention strategies in diverse settings. He is the co-chair of Oregon Psilocybin Advisory Board's Research Subcommittee and serves as co-director of Open Psychedelic Evaluation Nexus, also known as OPEN. Over to you, Todd.
All right, thank you. I will be presenting about our experience in Oregon on behalf of our community-wide research consortium and our co-investigators that you see here. We have no conflicts of interest and are funded, as Andrew mentioned, through generous support from the SAMHSA grant, as well as some OHSU Foundation support. So Oregon Psilocybin Services Program is licensed and operated and regulated by the Oregon Health Authority, our public health department. It licenses manufacturers as a closed-loop syndrome here, where manufacturers produce mushrooms that contain psilocybin, and these are tested by licensed laboratories and then distributed at service centers in Oregon that are also licensed. Licensed facilitators then coach people through the process of having a psilocybin experience. And to date, the Oregon Psilocybin Services Program has administered over 10,000 experiences for clients. What they didn't do was establish any mechanism for evaluating state-regulated services. So a group of us founded the Open Psychedelic Evaluation Nexus, or OPEN, which is a community-wide research collaborative housed at OHSU, the goal of which is to assess the impact of state-regulated psilocybin services. We have set it up as a longitudinal cohort study of people receiving services. It is interdisciplinary. We have lots of input from across the spectrum. It's non-commercial and hosted at Oregon Health and Science University. And I'd just like to take one step back and talk about our overall philosophy. We view psychedelic data as a shared natural resource, the purpose of which is public well-being and shared wisdom. We espouse collective stewardship, not ownership, and we actually reject the notion that data should be monetized. And we adhere to the highest standards of encryption, confidentiality, and security. To develop the cohort and data collection platform, we started with a tremendous amount of formative work over a 2-year period that is grounded in the community. Open functions and is guided by a community advisory council. And our early work characterized Oregon's emerging facilitator workforce. And I've listed the references down in the corner here that you can look up. We've also conducted a number of qualitative studies that identified expert facilitator priorities for safety and outcome measures. We just asked the community, what should we be measuring if we're going to comment on safety and outcomes of state-regulated services? We've published a paper on standards of psychedelic care that came out of that work, as well as facilitator personal experiences of psychedelics in their own lives, and have a forthcoming paper on informed consent. All of this also grew out of a tremendous number of meetings in the community in Oregon. Andrew shared a similar slide here, but briefly, facilitators are the ones who offer participation to their clients. Clients are offered an electronic one-page consent that they can click on if they want to participate or opt in. Facilitators on the day of services also enter key information about adverse events that happen during the actual services. And then for their part, clients complete surveys at baseline, and then 1 week after their experience, and 1, 3, 6, 9, and 12 months after their experience. All of this information can be entered on the platform in any from any device by URLs or QR codes or whatever works for that person. The information is securely housed in an OHSU data repository. And then as we get enough data to be completely confidential, the plan is to feed that data in an aggregate fashion back to the community service centers so they can use this for their own quality improvement purposes. Here's what we're measuring. And I'll just point you to the top row that shows the timeline where people are surveyed, and the left column, which highlights all of the domains that we're measuring currently in the open tool, although it's quite adaptable. The domains that are highlighted in red are our primary early hypothesis that focus on safety, well-being, and mental health. I should say also that so far the typical survey, the longest one is at baseline, and it takes anywhere from 11 minutes to 18 minutes to complete. Here's where we're at in terms of recruitment so far. We've enrolled 54 facilitators, and very excited to announce that as of a couple weeks ago, we initiated a pilot in the state of Colorado as well, and have 2 Natural Medicine Act facilitators now enrolled. The facilitators are working at 17 service centers in Oregon, and have enrolled 169 of their clients, including, as of yesterday, actually now 4 Colorado clients that have undergone experiences. Our retention is excellent, over 90% at all time points so far. And we just had our first two people enter the 9-month one. Facilitators were highly experienced, with the majority having a professional licensure and at least a master's in education. They were also highly experienced in psychedelic use themselves. Participants looked a lot like the participants in clinical trials so far. They were predominantly white, well-educated, and wealthy, and half were psychedelic naive. Substance use was common in the past 30 days, as were mental health symptoms. The top reasons for seeking psilocybin services, and people could check all that apply, right? So these are not mutually exclusive. The top reasons were curiosity and self-improvement, followed by self-management of mental health conditions and processing trauma. And of the first 157 people to complete a session, the mean total dose of psilocybin received on the day was 35 milligrams. 89% of sessions were individual sessions, and the rest were group sessions. And importantly, we've had 2 serious adverse events documented, or 1.3% of people receiving these services so far. One facilitator reported on the day of the experience a behavioral event where the client became physically threatening. They were referred to psychiatric evaluation. But 1 week later, the client themselves actually reported on subsequent surveys that no harm was done, and they were kind of sheepish and really appreciated the care they got. And this is the power of longitudinal assessment that allows documentation of trajectories over time. A second client reported after the session, a week later, that they required an ER visit for psychological symptoms. They had received 25 milligrams of psilocybin, and on subsequent follow-up surveys continue to report persistent psychological difficulties they're receiving care for. Both of these clients were psychedelic naive, and we'll have the opportunity, as more of these stories unfold, to drill down on them. For their part, the clients, the vast majority reported no harms at all. In the red, you see reports at 1 week, and the yellow at 1 month and 3 months. And you can see that over time, more and more people report that they had no harms from the experience as time goes on. The most common reported effects were hallucinogen persistent perceptual disorders. That these are things like changes in vision and flashbacks and things like this. This seems to diminish over time. I don't have the 6-month data on here for this one, but I can say there are 0 people reporting us. Also, no one reported that this interfered with their work or social life or family life. Headaches were also commonly reported. We asked clients to reflect on their experience at 1 month, and the vast majority indicated that they benefited from the psychedelic experience, 95%. 63% reported it as among the top 10 most personally meaningful experiences of their life, and 85% said their goals were met. We also asked them to sort of rate their experience, and almost everyone, to a person, said that they would recommend the facilitator in the service center, and that the value of the experience was worth the money that they paid. Anxiety symptoms declined on the HADS measure substantially over time, with 53% reporting moderate to severe symptoms at baseline, and that dropping to 13% at 3 months. Similarly, depression declined on the PHQ-9 scores, with 46% reporting moderate to severe symptoms at baseline, and that dipped down to 8% at 1 month and back up a little bit at 18%. At 3 months, it'll be fascinating to see what direction this all goes in subsequent surveys. Similarly, PTSD symptoms diminished substantially, with 51% of individuals reporting moderate to severe PTSD symptoms at baseline, and that dropping to 18% at 3 months. So open has several substantial strengths and limitations to be aware of. The strengths are that it's highly adaptable as a data collection platform, and that we're currently in the process of building APIs, for example, with other systems, and exploring how we might more efficiently link to other practice management data systems out there, and perhaps even electronic health records like Epic. The longitudinal cohort approach yields very granular long-term information on psychedelic experiences that you really just can't get any other way. So it's more of a deep approach than a broad approach. We can also link information from service centers, facilitators, and clients. So we can rate the correlates of those factors with outcomes. We also have conducted this, like RMPDS's Insight, with a high degree of scientific rigor and privacy protection. The limitations are that this may not represent all people accessing psilocybin services in the States. And we have benchmarked so far to the first release of the Oregon Health Authority's mandatory data reporting that was issued late spring. And it looks like we're capturing currently about 10% of the people coming through state services in Oregon. We hope to dramatically increase that proportion moving forward. Reassuringly, the demographics and reasons for use looked almost identical, actually, to those for the broader Oregon population. Secondly, Open can't really assess national population trends. Because it's focused just on the state services. We're not capturing recreational use outside of the state services currently, although we have the approval to do that, and we could potentially adapt. But the reality is that these larger population assessments that Insight does are more effective and nationally representative, at looking at large, statewide trends over time of who's using both inside and outside of the state-regulated services. We also have a number of opportunities of using open as a platform for other projects, right? So we're currently partnering with RMPDS and others on NIH applications, for example. We are partnering with the group at Emory to conduct in-depth research on safety events. We've completed risk reduction intervention assessments and would potentially be able to field those. We just completed a veterans peer support training curriculum pilot that went on at the Portland VA Medical Center, and are exploring and expanding in Colorado for sure, and seeing if there's any way that it might be appropriate to support New Mexico in documenting the experiences of people coming through their programs down the road. Again, this is highly adaptable, so we can actually tweak things and tailor them. The reason we're in the pilot in Colorado right now is we want to make sure we're getting it right, and before a broader expansion. And then we also have the capacity for broader clinical trials. So last slide. Open is highly feasible. We can confidentially track safety and outcomes of clients receiving state-regulated services. And our early findings suggest few safety events, although not zero, and decreased anxiety, depression, and PTSD symptoms over time. Our next steps are ongoing recruitment and analysis, as well as you heard Andrew's talk about the Scope Center. We're very excited to really be generating a national resource of the data mosaic for use across the country to inform policymakers, the public, and everyone interested on psychedelic data and policy. Thank you, and I'll stop there with some lovely Colorado aspens on the right.
Thank you, Dr. Korthuis, for sharing these important data, and I'm excited to see that you are now piloting in Colorado. Looks like we have time for one or two questions. The first is, you mentioned the outcomes approximated clinical trials, but most of the reasons for use were self-expansion, which isn't necessarily a trial indication. Could this cohort be biased towards positive outcomes?
It's an excellent question, and this is why we're measuring both multiple measures of safety and harms, as well as positive outcomes. And we are not exclusively focused on medical outcomes, because you're correct. The majority of people seem to be using it for general self-improvement or other experiences. And so I didn't share this data, but we're also measuring things like well-being, and life satisfaction, and I'm not prepared to share that data today, but it's positive, I'll just say, and as well as actually triangulating with qualitative in-depth interviews as the next step to really understand people's experience of what they're getting out of it and taking away. So I would say no, it's not biased toward positive outcomes. We're viewing this very objectively, and trying to document the full experience that people are having.
Wonderful. That's all the time that we have for today. Thank you for your presentation.